So, good morning. Thank you, Pablo, to invite me to present these educational sessions about expanding field of surgery in neuroblastoma. So, as you know, neuroblastoma is the most common extracranial tumor, solid tumor in children, and neuroblastoma results of an oncological damage during the neural crest cells development, migrations, and differentiations. We have the habit to describe neuroblastoma according to the locations of the tumor, but for the surgeon, it's probably more useful to have a description according to the sympathetic structures involved in the neuroblastoma. We described paravertebral neuroblastoma, as in cervical, thoracic, or abdominal locations, and the periarterial and adrenal neuroblastoma, which is the most frequent neuroblastoma. Locoregional extensions of the neuroblastoma can be explained by the huge connection between all these sympathetic structures, and as you can see in the right of the slide, that adrenal neuroblastoma can be expanded around the renal pedicule or cross the midline and extend around the aorta. You know that now we know that origin of neuroblastoma can be associated to the biology, and more specifically, periarterial neuroblastoma and adrenal neuroblastoma are associated to a worse biology, and probably that can explain the difficulties of this surgery. As you know, we stratify now neuroblastoma according to the ENRG-SS classifications, and it's based on two major criteria: the presence of a metastasis and the presence of imaging-defined risk factor that will impact the surgical risk factor. IDRF is probably the most homogeneous descriptions of neuroblastoma we ever had. With this ENRG-SS classification, we had 6 other criteria, as you know, to define the international neuroblastoma risk group. So the age at diagnosis, histology, tumor differentiation, and some also biological factors. And we've defined very low, low, intermediate, and high-risk neuroblastoma that will influence the treatments. So for the surgeon, there are 3 main questions. Do I have to operate this patient? If yes, when I have to do it? And finally, what should be the extensions of the resections? You know that for some patients, we can do a wait-and-see strategies. Especially, it's very known for the perinatal neuroblastoma and the MS neuroblastoma, which can be cured in 80% of the case without any treatment. In these SciOpen studies of perinatal neuroblastoma in patients less than 3 months without MECAN amplifications, they show that surgery has been performed in only 30% of the cases, and 45% before and 55% after the 48 weeks of observations. In these studies, they showed that the solid tumor and the huge mass at diagnosis are associated to a lesser chance of spontaneous regressions. And the patient will have had a surgery before the end of the observations. It's the patients with events, and events were defined by a progressive disease in local site or for the metastatic evolutions. Finally, the German group showed also that we can expand the wait-and-see strategies to the patient less than 1 year with L2 tumors and favorable biology, and they showed that in the observation group, 60% of the patients received any treatment. And the age at the regressions of the tumor, it's around 12 months and not seen after 20 months of evolutions. So in the LINES protocol, you know that for the very low risk, we can do an observation in some patients. The first one is a MS patient less than 12 months with a favorable disease. And if there are some life-threatening symptoms, you know that we can do chemotherapy for the symptoms, and after that, observe the tumors. For the patients with a L2 tumor less than 80 months and a favorable tumor, you can do also an observation. For all other patients in these both groups, you have to do a surgery if IDRF became negative, and if it's still positive, you can discuss with the SIOPEN committee surgeons. For all other patients, a surgery is mandatory. For one L1 tumor, it's the first treatment, and other one receive neoadjuvant chemotherapy. But what we could expect of the neoadjuvant chemotherapy? In these both studies, you can see that the number of IDRF diagnoses and the location of IDRF will influence the evolutions of the IDRF. In 30% of the patients, IDRF will disappear. And finally, they show also that the IDRF evolutions is correlated to the quality of resections. Of course, this decrease or disappearance of IDRF are associated to a higher chance of complete resections, but both groups are not associated with the prognosis, except for one case when the IDRF is still positive around the celiac axis and the superior mesenteric artery. At the end of neoadjuvant chemotherapy, these patients are more risk of incomplete surgery, and that can be impact the prognosis. So now, if you look at the abdominal and pelvic neuroblastoma, for the surgeon, the challenge is the adrenal locations due to, as I already said, the risk of extension around the renal pedicule and the risk of nephrectomy, but also the risk of infiltration around the aorta and the risk of vascular injuries, with a vital risk for the patients. For the paravertebral location, the risk is to do a neurological damage in these cases. You know that some patients present a neuroblastoma just around the renal pedicule, and for this patient, of course, the risk is the nephrectomy. And probably for the surgeon, the best location is the neuroblastoma in the Zucker-Kandel ganglia, because we know that for this location, we can cut the inferior mesenteric artery without any issue. Now, when we look at the neuroblastoma in the cervical and thoracic place, we distinguish the paravertebral neuroblastoma to the neuroblastoma in the cervical location, more specifically in the stellate ganglia, and finally periaortica. For the stellate ganglia neuroblastoma, the best approach is the transmanubrial approach, because we have a good view of the vascular pedicule and the nerve, and it's a very good approach with a good recovery for the patients. Finally, the paravertebral neuroblastomas, you know, the risk is the extensions in the spinal canal and the risk of compressions of the medulla. And you know that for the management of the dumbel neuroblastoma is required a chemotherapy in case of neurological symptoms before surgery, and we can do a surgery first in case of absence of neurological symptoms, and we can do it for the extra spinal part if the extensions in the spinal cord is less than 1/3. Finally, the major question is still open. It's the indication of surgery in high-risk neuroblastoma. In the literature, you can find some studies for or against surgery for this group of patients. But if you look at this study, the problem is that all this study is really heterogeneous, with an heterogeneity in the treatment, but also in the descriptions of surgery and the quality of the resections. So we hope that with the new protocol, we will answer to these questions of the role of surgery for high-risk patients. First, they indicate the surgery, the timing of the surgery. So patients have to be operated at the end of induction chemotherapy, except in case of persistent encasement of celiac axis or superior mesenteric artery or both renal pedicule. But the most interesting in this new protocol is the very well descriptions of the quality of resections. So they defined a complete resection where there are no macroscopic residual disease. The excision with a minimal residual tumor is when there are a residual tumor less than 5 milliliter, estimated by the surgeon, but also by an MRI or MIBG after the surgery, and an incomplete resection when the residual tumor is more than 5 milliliters. And based on this, there is a randomization in the radiotherapy treatment. So the macroscopically complete resections will receive a radiotherapy in the preoperative bed tumors. But for the two other groups, so the minimal residual tumors or the incomplete surgery, they will be randomized between the classical radiotherapy in the preoperative tumor beds, and the second group will receive also a boost chemotherapy on the residual tumor. And with this new protocol, we hope that we can answer to the questions about the role of surgery in high-risk hepatoblastoma. And before to decide that this patient is not indicated for the surgery, I think you have to discuss with the CIOPEN surgeon committee to have the good treatment for these patients. Finally, just few words about the minimally invasive surgery in neuroblastoma. Now, with the laparoscopic robotic assisted surgery, we can do a resection for the L1 tumors and for also some L2 tumors in expert centers. And in these studies, they report a macroscopically complete resection in 75% of the cases and more than 95% of resections in 20% of the cases. Interestingly, in the multivariate analysis, they showed that the patient with more than one IDRF or volume of tumor more than 100 milliliter are associated to higher risk of conversions. Surprisingly, the L2 tumor and the tumor with a MYC amplifications is associated to a higher chance of total resections, and metastatic patients are were more recurrent. And finally, the complications are associated to the L2 tumor and the tumor with a huge volume. So I just want to conclude that neuroblastoma is an heterogeneous tumor with a multimodal approach. And for some patients, you can do a wait-and-see strategies, but at the end of these wait-and-see strategies, you should discuss for the surgery for the residual tumor. Other patients will receive a neoadjuvant chemotherapy, and the surgery have to be done as complete as possible, because after that, you can treat the residual disease with the radiotherapy. Minimal invasive surgery is now a good option for the L1 tumor and can be discussed for the L2 tumors in some cases. Thank you to my team, and thank you for your attention.
So thank you very much for the very interesting presentation. Maybe we can go now to some questions, if you want, for the surgical part. So I hope you have a lot of questions, some questions. Just to wake you up, can you just raise your hand, whom of you are surgeons in the audience? How many surgeons do we have? They're a bit scared. How many radiation oncologists do we have? They are less scared than the others. Scared. How many pediatric oncologists?
Yeah.
How many advocates or parents' representatives? How many something else that I forgot to say? Sorry. Nurses, for example. Yes. Okay. So questions. Don't be shy.
I think the questions go to the oncologists that you have to help us removing these things, you know. It's difficult for us sometimes.
I don't know if we have, you can go there.
Hi, I'm Tim Rogers, surgeon from Bristol, so I feel a bit obliged to ask a question. But I just wondered what your advice would be in terms of tumors that are in the lower thoracic region, where we're concerned about spinal cord ischemia and how you manage those. So, tricky question, and ask it because I often have the dilemma. and how to proceed with these and how to protect the spinal cord?
Yeah. Yes, it's a very good question. I want to answer according to the answer we'll give by Professor Sanaki. They say that she never seen until now a damage of the spinal cord in this case of patients. And now we are going to do a study about this case. We want to study all these low thoracic location of neuroblastoma and see if there are some complications after that. But she said that for now, she never seen that. Some team are going to do an arteriography before the surgery to see the artery, but for now, we didn't see. I don't know if all other surgeons can talk about that, but we don't have any complications after the resection of these tumors.
Yeah. Hi, good morning. I'm Shui Yen. I'm a pediatric oncologist from Singapore. Regarding the high-risk patients with gross disease elsewhere, do we ask the surgeons to resect them all if they are resectable?
Yes. For me, yes. You have to ask to your surgeons, but we have to do it, but we have to avoid major complications. So let's in place some residual disease. It's not a problem because we know that they are going to have a radiotherapy, but the maximal resection for us is really indicated in these high-risk patients.
Thank you. We do the same. Thank you.
Thank you. Vasilius? Go to a microphone.
For the previous question, the lower thoracic area masses, they're listed as L2. Should we revise that? They are listed
Yes.
as L2, not
Yeah.
L1. So
Yeah.
should we revise that? Or put an asterisk and say, provided, blah, blah, blah?
I think for L2 tumor in the low thoracic, you can go to surgery after the neoadjuvant chemotherapy. It's indicated for me. Yeah.
Yeah, but I mean, we have it as an L2 because of the vasculature there. So maybe we have to revise that or put an asterisk.
You mean the EDRF
Yes,
description?
yes, on the
So
IDRF.
it's true that sometimes they are not so some of them may
Yes,
revise.
but by practice we can, update.
So I think that the key message here, I think for me at least as a pediatric oncologist, is that surgery of neuroblastoma is complicated. So we have complicated people like surgeons that take care of that. And I think that the message that you said before, the colleague from Singapore, is very important. So in high-risk neuroblastoma, surgery is very, very important. And the most important thing is to discuss, as we do in SciOpen, with the people. So it's impossible nowadays that someone in their corner, in their country, in their center, decides by themselves not to operate a patient with a high-risk neuroblastoma. Maybe the surgery is not feasible, but it's not the same when you have discussed that alone in your corner than you have discussed with the people that may have the knowledge. So I think that the message here is surgery is very important, even if a patient with a widely spread metastatic disease like high-risk neuroblastoma, and that we are lucky to have very good surgeons in many countries that work together. So please just contact them and use the sources that we have, the resources that we have in CFM for those patients. So thank you very much, Aurore.
Thank you.
So now we go to the radiotherapy part. That is going to have, we are going to have Tom, you know him very well. So he's a radiation oncologist that works at Ghent University and at the Belgium Proton Center Particle. You know him very well for some years, a few years. And you also know him because when you said quartet, you think also of Tom. And some of you may have received a lot of emails saying, please send me the PDF, the information of the patient to be able to review the imaging for the radiotherapy. So thank you very much, Tom.
Thank you, Pablo. Good morning, everyone. I'm a bit scared by all the pediatric oncologists in front of me, talking about a subject which many of you won't like. But I will try to explain to you that you may need to like radiotherapy more than you think you do. I have no conflicts of interest. So why would we use radiotherapy? Aurore already explained to you what the origin of this is interesting. Already explained you. We'll try to This one, okay, right. Yes, this is going to be better. And now there is a discrepancy between what I see here and what I see on the screen. This is really interesting. So Aurora already explained to you that neuroblastoma is originating from adrenergic neuroblasts of the neural crest tissue. And what is important for us is that this is radiosensitive tissue. And this is important because it also means that the dose of radiotherapy that we can use in neuroblastoma is actually quite low. It's similar to what we do in Wilms tumors. It's far below what we have to do in brain tumors. We also know that radiotherapy is important to reduce local failure, and this is something which applies to almost any tumor. And as this type of tumor is quite sensitive to radiotherapy, it even works if we give rather low doses. Another point, I will not discuss about it today, but as you all know, MIBG can be used to treat neuroblastoma as well. This MIBG is concentrated in the neurosecretory granules of the cells. We can couple this MIBG to a radioactive molecule, which is iodine-123 for diagnostic or iodine-131 for therapeutic purposes. We can combine these, we can couple them and use them to treat the tumor. Right, so evidence for radiotherapy. Well, if we are very strict, this evidence is actually very, very weak. And we hope, as I will explain to you, that with high risk 2, Saipan high risk 2, we will give a little bit more evidence. Because this has to do with the fact, and Aurora already alluded to it, it's almost all retrospective data. Endpoints are quite different in the different studies. You've shown the current staging system, but if you look historically, this staging system has shifted quite a lot. So some tumors which were belonging to stage whatever have now migrated to stage whatever. So be careful when looking at older data. Sometimes they have been grouped, sometimes they have been split. We have changed quite a bit on target volumes. We have reduced them even during the running of high risk 1. We have reduced our volumes for radiotherapy. And in the past, there have been quite a lot of radiotherapy schedules. I will give you a few examples of them, even within one single study or within one single trial. So, for example, what you see here is an overview of some older studies. They're all retrospective except, oops, this is not what I wanted, except the one with the arrows. That's the only randomized trial that we have on radiotherapy. Unfortunately, it's a combination of high risk and intermediate risk patients. But what is important is that in almost all of these retrospective series, you see that the local control for these patients is better with radiotherapy. So what is the indication, or what do we think are the indications currently for radiotherapy? For low and intermediate risk neuroblastoma, this is actually quite limited. This is the so-called group 8, which is the only more or less recognized indication for radiotherapy. For high-risk neuroblastoma, this is somewhat different. And high-risk neuroblastoma is defined as patients who have stage 4, or patients who have a stage 2 or 3, but have MYC and amplification. So all these patients qualify to be called a high-risk patient, and currently, at least for Saipan, we treat them in the high-risk neuroblastoma 2 trial. This includes patients who are 1 year or older, and patients who have MYC and amplification and who are not 1 year or older also qualify to participate in this trial. This is the overview of the whole trial. You have already seen it. I will not go into too much detail. I will focus on the last but one block in this scheme, which is the radiotherapy. As I told you, radiotherapy, we know that it has a certain role to play in neuroblastoma. What we do not know is what role exactly has radiotherapy. So everyone, more or less, even in the States, agree that local treatment is important and that we should give a dose of around 20 gray. What we do not know is whether, if a patient has residual disease, this 21 gray or 20 gray is sufficient. This is something we do not know. And Pablo just told you that surgery is important. I'm the first one to say that surgery is very important. Radiotherapy is not something that can replace bad surgery. Everyone awake? Yes. What we want to know is that for the cases where the surgeon is unable, for whatever reason, and that reason should not be incompetence, but if the surgeon is not able to remove that tumor, what we want to know is whether giving more radiotherapy is of any use. That's the main question of high-risk 1. And this is the reason why we're randomizing these patients between the standard dose, 21.6, or 21.6 gray, with a boost up to 36 gray. So that's the question of this trial, because we don't know. We give the treatment around 2 to 3 months after the high-dose chemotherapy and autologous transplant, stem cell transplantation. The dose is 21 for the standard patients, so those who have not any residual disease or those who are randomized to the standard arm. Because, as I told you, we do not know whether this is useful or not. There is some retrospective data, and this data is conflicting. You have the American data which say that's of no use. You have the German data which say, yes, well, that may be very interesting to give some more radiotherapy if there is residual tumor. But the true answer is that we do not know it. And the question of high risk 2 is to try to give an answer to that question and to try to find out whether it makes sense to give a higher dose, which also means to give more toxicity, to give more morbidity to these patients. We do not want to give more toxicity if we do not have any outcome which is in favor of the patient. The volume that we use is the volume that we see at the moment of surgery. Just before surgery, imaging is very important, and we will have a look at that volume, and we will use that volume to treat the patients. At the moment, we do not systematically irradiate metastatic disease. We may come back on that during the day, because we as radiation oncologists would love to have another randomization, not in this trial, but in another trial, to have another randomization to find out whether, as again some people do and others don't, irradiation of metastasis is also of any use. We do not treat elective lymph nodes. We do treat lymph nodes which are invaded and which belong to the immediate vicinity of the primary tumor, but we do not treat elective lymph nodes. And we do no longer use TBI. TBI has been used in the past, but is obviously now abandoned because we have much better ways to prepare patients for autologous stem cell transplantation. So we start with what is called a preoperative GTV. That's the tumor as we see it on the pre-surgical imaging. And we will adapt that, because that's the difficulty for radiotherapy. We start from a nice tumor on a nice scan, then the surgeon comes in, and everything is gone. But we have to treat that area where the tumor was. So it's extremely important that those two scans are combined, that we try to project the original tumor volume onto the scan that is used for the treatment, for the radiotherapy treatment. We will add a margin to that. That becomes then a CTV, not going to explain all the details. And then we have to give another margin because patients are moving, organs are moving, and we have to call that a PTV. As most of these children are young, are very young, it's important to include whole vertebrae in order to avoid scoliosis. And as I said, there was a nice tumor pushing all the organs away. Tumor is gone, organs come into the place of the tumor. We have to adapt that volume in order to avoid that we treat a lot of normal tissues. This is what we have to deal with. On the left side, you see the original primary tumor. It's on a CT scan because it comes from another hospital. And then after chemotherapy, we get an MRI, and we have to try to combine all that in order to define what we're going to irradiate. Okay, radiotherapy is an interesting treatment, but it may also have some problems. And we are treating very young children. I think my youngest child I've ever treated was a child with neuroblastoma, just a few months old. Most of the patients also get intensive chemotherapy, and this chemotherapy gets more and more intense, which is not only a risk factor on itself, but it also may increase the toxicity caused by the radiotherapy. Most of the tumors, as Aurore explained to you, are in the abdomen. So the tumor is surrounded by all kinds of organs which are quite sensitive to radiation, especially kidneys, but also intestine, pancreas. This is all surrounding the tumor. So we have to be very careful in order to treat the tumor site well, but at the same time try to spare the organs at risk. And as you all know, there is a magic trick for that. That's protons. Let's give protons to all patients. What is the advantage of the protons? Well, you see it here. On the left side, you see some proton plants. On the right side, you see some photon plants. And indeed, there are advantages for protons, but not for all patients. The major advantage of the protons is what you see behind. When we come from the back, as we do here, we can make the protons stop at a certain level, and there will be no dose beyond that point. This is completely different for the photons. The photons, they will keep giving dose. It will be less, but they will keep giving dose to the patient. But there is also an important other point, and it is that at the lateral sides, protons are much less precise than photons. Actually, depending on the energy of the protons, this is not going to be a course in radiophysics, don't worry, but depending on the energy of the protons, this, what we call penumbra, this spread out of dose, is even worse for some protons than for the old cobalts. Some of you may remember that we used cobalt machines about 50 years ago. So for some patients, the protons will be very useful. For others, the protons will be not so very useful. They're anyhow very useful if we look at the development of secondary cancers. This is a quite complicated slide, but it's not that complicated. It simply tells you the dark bars are simple radiotherapy, the gray bars are somewhat more complicated radiotherapy, and then the white bars are protons. And as you see systematically, there are less secondary tumors when you give proton therapy. Take care, because we have a much longer period where we have been able to look at secondary tumors for photons than we have with protons. The secondary tumors, they may appear years and years after treatment, and we haven't yet the experience of many decades of treatment with protons. But, as I told you, there are some cases where the protons can be better, and this is what you see here on the left side of the slide. It's clear that the combined kidneys are doing better with the protons. But if you look on the right side of the slide, this is completely the opposite. There, the protons will give much more dose to the kidneys than the photons will do. And this has all to do with the fact that the tumor is there in between the kidneys, we try to give the dose to the tumor, but we're irradiating more kidney than we actually would want to. And the colleagues from UK, from London, they have been looking into this, and they have found that, especially for large, anteriorly extending tumors, which are situated in the middle of the abdomen, you have to be very careful with thinking that protons are the magic bullet. Another important point is that protons are much less forgiving for changes in anatomy than photons. And especially air can be a big problem. So this is something you also have to take into account. This is the flow chart that our colleagues have developed. They say if you have a unilateral tumor or a midline unilateral tumor, it's quite probable that protons will be better. But if you have a bilateral midline tumor, do not think that protons will be the magic bullet. At least think of making 2 plans with both protons and photons in order to give the patient the best treatment. General anesthesia, most of our patients are very young and need general anesthesia. This will also influence the air, and this may also have a bad influence on the distribution of your protons. Last point, quality of radiotherapy. Extremely important. This is what we found when looking retrospectively to the patients that were treated in high risk 1. And we see that there is even an influence on overall survival for patients who have not been treated according to the protocol. Their survival is worse than for those patients who were treated exactly as the protocol had prescribed. So, I think that radiotherapy is important for neuroblastoma, not only in order to achieve local control, but also because treatment results for neuroblastoma have improved. So local control has become an issue. We can do it with rather low doses, in addition to resection. I insist again, we need the resection. It's a difficult area to treat with protons. The majority of the patients will definitely have a benefit of the use of protons, but not all of them. So be careful with that. We do not know whether residual disease needs a higher dose or not. We do not know that. And we certainly do not know that we can replace bad surgery by additional radiotherapy. This is the question that we're asking in high risk 1. Do we have to boost this residual or not? And last but not least, use an individualized approach for all patients. Do not think that there is something that fits all. Thank you.
Thank you very much, Tom. I'm sorry because we started a bit late. So maybe just one quick question, and
yes.
that will be out. Sorry.
Thank you very much for this interesting presentation. I think that the radiation oncologists here are doing protons since a certain point, a certain time. Agree with you that abdomen in general is not the easy way to treat the patient. But I'm a little bit concerned about the message you are giving to the pediatrician that there are patients, yes, agree, there are patients a little bit more difficult to treat with the protons, but also with the photons. But you are presenting a old comparison with also old approach, technical dosimetric approach. Now, in protons, we can use more and more what is called ferrobustness optimization, which is where the idea is also to be closer and closer to the volume. For sure, the anatomical changes is a key point for protons because we have to replan and to check and check and check. But this is not the reason not to evaluate for all the patients the benefit of a proton therapy. This is the first point. The second point, I agree, the metastatic disease in the bone is something that will be addressed in the future probably, because nobody now describe and knows if the regression pattern in a vertebra is the same than in a huge metastasis in the skull base and orbita. So these are two open questions, but for protons, please, I think that we should give anyway the chance to this technique to be applied with a new technique, a new development in planning and in dosimetric skills to this kind of patient. Children.
Yeah, well, very quickly, because I think we have to stop. There is another session here. I absolutely agree. I just want to bring the message that protons are not fitting for all patients, right? That's the important message. The majority of the patients will benefit from protons, but not all of them. And we know more or less beforehand, we can assess for which patients it may be useful. That's what we've shown for the tumors that are anterior or that extend quite anteriorly, the tumors that are in the middle, because there you may have this problem with the kidneys that will have a higher dose. So that's the main message. Do not think that these patients will by definition benefit from photons. No, you have to make the comparative plan. That's the main message, yes. And the metastatic disease, let's leave that for this afternoon.
So thank you very much, and sorry for being a bit late. Thank you very much. Thank you.